Hello, thanks for having me. I'm Dr. Alvarado. I'm a nephrologist with San Antonio Kidney, and today I'd like to share with you two cases of Alport syndrome, and specifically how the genetic testing helped me diagnose, manage, and treat two patients. So the first case example is a patient with Alport syndrome. This patient is 53-year-old with ESRD who had been diagnosed with chronic kidney disease in the past year. In terms of her clinical history, she had a 20 to 30-year history of moderate hypertension with intermittent follow-up. She had 3 grams of protein in her urine studies. Blood work showed negative serologies. I had a clinical suspicion of Alport syndrome. We were unable to do a kidney biopsy for multiple reasons, but mainly because her kidneys were too small to be biopsied. She had a very pertinent positive family history of kidney disease. 2 sisters had end-stage renal disease and actually had kidney transplants in their 40s. In addition, her mom died in her 60s from end-stage renal disease and was on dialysis at the time. So this patient I thought was a good candidate for genetic testing. And so we went ahead and proceeded after I talked to her at length about it. And we came up with a positive result, specifically of a variant identified in the COL4A3 gene. So this was consistent with autosomal dominant Alport syndrome. So this was clinically useful for several reasons. For one, it confirmed my diagnosis of Alport syndrome. This was helpful because I was able to refer the patient to other specialties, specifically audiology, ophthalmology. In addition, this allowed me to counsel the patient's family and talk to them about further testing. This was important because 50% risk for first-degree relatives, being that this was likely an autosomal dominant disease. And finally, it gave me an opportunity to improve on transplant planning. Her son was undergoing evaluation for transplant, and there were several living related possible donors. And so having this genetic confirmation and this diagnosis was helpful to transplant planning for the patient as well as for her family. So the next patient I want to talk to you about is a patient who ended up having Alport syndromes as well as polycystic liver disease. Again, the idea here is that I used genetic testing to supplement my clinical diagnosis and management of another patient. This patient was a 38-year-old patient that presented to the clinic with proteinuria. The evaluation showed 5 grams of protein in the urine. The patient underwent a biopsy that showed FSGS. Other pertinent clinical history included that the patient had hearing loss, vision impairment. On the other hand, the patient had normal kidney function and did not have any hematuria. In getting to know the patient, it was revealed that they had a family history of kidney disease. The patient's brother had hereditary nephritis. In addition, the patient's mom and uncle both had end-stage renal disease. So this is the clinical background in which the second case presented. After I discussed genetic testing with the patient, we went ahead and proceeded. This patient ended up having positive variants for the COL4A5 as well as the PRK CSH gene, so essentially consistent with Alport syndrome and polycystic liver disease. The patient was also found to be a carrier of hyperprolinemia type 1. So the molecular diagnosis was very fruitful. So this patient had a positive genetic variant for 3 different types of diseases. This was helpful for many reasons, but we'll talk about polycystic liver disease type 1 first. This disease involves multiple liver cysts and can often progress to liver enlargement as well as liver failure. Patients sometimes get kidney cysts, although it doesn't generally result in significant kidney disease. And common management can include hepatology evaluation for the liver disease and imaging studies to assess the cysts is clinically indicated. So for this second patient, genetic testing was very clinically useful for the following reasons. So it allowed us to identify a dual diagnosis of Alport syndrome and polycystic liver disease. In addition, it allowed us to proceed with family counseling and testing because of the risk to other biologic relatives. This was specifically important because of the potential for carriers of the hyperprolinemia type 1 gene, and allowed us to consider partner screening as well. And finally, extrarenal referrals were possible because we did the genetic testing. In this case, we had to consider hepatology referral for the patient. So overall, a very clinically useful test that, combined with the presentation of the patient, helped us diagnose, counsel, further manage the patient. Thank you so much for your time. Again, I'm Dr. Alvarado. I'm a nephrologist with San Antonio Kidney. Appreciate your time today.